First of all, inguinal canal anatomy. The inguinal canal is stitches from the deep inguinal ring to the superficial inguinal ring. This is a canal. Contains within the canal and differ by the sex, like spermatic cord in male and round ligament in female. Also contains three important nerves of ilioinguinal, genital branch of
I
genital.
think it will be a good idea if you can put your presentation on the slideshow.
First of all, we'll be discussing inguinal canal anatomy. The inguinal canal is stitches from the deep inguinal ring to the superficial inguinal ring, which contains spermatic cord or round ligament according to the sex of the patient. And a nerve, it also contains ilioinguinal nerve, genital branch of genitofemoral nerve. Its boundary is made by anteriorly, it is by external oblique and internal oblique, and posteriorly, it's from fossa transversalis. The roof is made by the conjoint tendon, which is made of transversalis, transversus abdominis and internal oblique. Our floor is made of inguinal ligament.
Floor is made by the
Inguinal ligament and reflected part of.
no, go back. So and external oblique and internal oblique, anterior wall, that's fine. Posterior
uh,
wall by transversalis fascia
so,
and by the conjoint tendon. So in
yes,
the
sir.
medial part, in the most medial part, just behind the external ring, this particular structure, conjoint tendon, comes and takes part in the formation of the posterior wall. Okay, back
Okay,
is
sir.
posterior wall, right? The
Okay, sir. Yes,
roof
sir.
is the arching fibers of the internal as well as the internal oblique and the
Trans-
transversalis abdominis muscle.
yes, sir.
Transversus abdominis muscle. And the floor is formed by the
Inguinal
inguinal ligament, and maybe a part of it is also contributed by lacunar ligament. But
lacunar. Yes, sir. Medially by lacunar ligament.
yes, so this is a very important thing that you should always remember. What forms the various boundaries of the inguinal.
Inguinal.
ठीक है. And
Uh,
these diagrams should be very carefully understood by you. And also in today's time, it's also important to know the anatomy both from the anterior perspective for the open repairs and from the posterior perspective for the posterior repairs and laparoscopic repair. ठीक है, चलो.
yes. This is the neuroanatomy of the inguinal canal, where we will be identifying the three important nerves. Will see while opening the canal. These nerves are ilioinguinal, that is anteriorly. Second one is genital branch of genitofemoral. Third one is iliohypogastric. Ilioinguinal nerve is located over the spermatic cord within the investing fossa of internal oblique muscle, and the genital branch of genitofemoral nerve is under the spermatic cord, running adjacent to the spermatic vein. This is highlighted in blue colors. Iliohypogastric nerve runs between internal and external oblique.
So the important part is that ilioinguinal comes, it exits from the external ring. The genital branch also exits from the external ring. Both exits from the external ring. Whereas iliohypogastric, goes medially and lies between the internal oblique and the external oblique muscle.
Yes, sir.
Yes. So this anatomy is very important. You have shown it very beautifully. Good.
The definition of the inguinal hernia is protrusion of abdominal cavity contained through the inguinal canal. It is inguinal hernia. What are the indication of open inguinal hernia repair? Then the first is incarcerated or irreducible hernia. Second one is obstructed inguinal hernia. Third one is strangulated inguinal hernia. And fourth one, recurrence in the previously operated laparoscopically or open hernia repair. Or
I think what is this indication you are saying about the open, or you are
open,
saying?
open.
Huh?
These are the indication of open hernia, open groin hernia repair. Sir.
So I think that is something which needs to be debated and discussed.
Sir.
All hernias can be operated by the open
Open.
method. So therefore, every hernia can be operated by open methods, but there are few hernias which cannot be operated by laparoscopic method.
Yes, sir.
राइट तो इसमें सबसे ऊपर ही आना चाहिए था symptomatic
Inguinal.
inguinal hernias.
Sir.
But here there is, of course, a good competition and options between the two procedures. Okay. So
Yes.
symptomatic hernias are always an indication for surgery. Asymptomatic hernias can be left for observation. तो यही मैं बताया था ना कि जब तुम ऐसे बताते हो तो उसमें अपने सबसे बड़ी इंडिकेशन जो होती है वो
Sir.
सिम्प्टोमेटिक इंग्वाइनल हर्निया वो आपने छोड़ दिया क्योंकि आप देखते हो कि हमारे यहाँ पे सारे हर्नियाज अनलेस दे बिलोंग टू दिस कैटेगरी आर ऑपरेटेड बाय
Laparoscopic.
laparoscopic method. So that's why you have excluded it. That's what you have to correct. That every hernia where there is an indication to operate can be operated by the open method, and the choice depends upon what patient desires. Number one, if you are talking about where there is a competition between the two methods and the experience of the surgeon. So if laparoscopy can be applied or open surgery can be applied, it's the patient who can choose what he wants. And second is that what is the experience of a surgeon. So here I want to tell you one thing, that unless you have done 25 cases of laparoscopic hernia repair, your recurrences would be high. So therefore they say that to become a reasonably expert laparoscopic surgeon, you should have done about 25 cases by laparoscopic surgery, and then only you can say that yes, in my hands laparoscopic surgery can be safely applied. Okay, got the point?
Yes, sir. Yes, sir.
Chalo, move on. But everything that you have written is very correct, and that
Sir.
means that these are the situations where you cannot do laparoscopic surgery, and
Yes, sir.
therefore you
Definitely.
would be doing this open surgery in these situations. Okay,
Yes, sir.
right.
Anesthesia in for doing the open hernia surgery, we can give general, local, or regional anesthesia for the patient. Currently,
Mhm.
the EHS guideline recommend that local anesthesia be considered for all the patient with a primary reducible unilateral hernia undergoing an open repair. Additionally, that this EHS warns that regional anesthesia has no advantage recorded over the local anesthesia for the patient and increases the risk of post-operative urinary retention also.
Yes, I think by and large, if you are comfortable with the uh, technique of giving local anesthesia, I think there is much to recommend it. Only thing is that it requires patience and it requires a little more time because you would be giving anesthesia in a very standardized manner. And I think the technique of giving local anesthesia by itself is very important, and one has to develop a good understanding with anesthesia colleagues that what is the best method, how to prolong the action of local anesthetics, right? And
Yes.
the beauty of it is that patient can be just up and about once he becomes pain free after surgery, and can be he can start eating within few hours of his surgery. So I think these are the many advantages of local anesthesia, besides of course the cost advantage. The cost of doing local anesthesia is much less than giving general anesthesia, but general anesthesia of course is a necessity in laparoscopic surgery. Move on.
The classification of inguinal hernia. First one is NIHS classification, which is classified into type 1, 2, 3, 4. Type 1 is indirect inguinal hernia with a normal internal opening. Type 2 is indirect inguinal hernia with enlarged internal ring. Type 3 is type 3A, type 3B, and type 3C, where type 3A is direct inguinal hernia. Type 3 is indirect hernia with posterior wall involvement. And type 3C is femoral hernia. Type 4 is recurrent direct. Type 4B is recurrent indirect. Type 4C is recurrent femoral, and type 4D is recurrent with combination or undetermined type, which we cannot classify.
I have been seeing these classification, and I don't think there is much practical utility of this except for exercising your memory.
Uh,
One has to know whether it's a inguinal hernia or it's a femoral hernia, whether it's a recurrent hernia or it is a non-recurrent hernia. Other than that, direct, indirect, all this confusion will be sorted out the moment you will explore the inguinal canal. Okay, so I think this only is from the point of view of exercising your memory. Other than that, I don't find any practical utility of this NEHA's classification of inguinal hernia. And today, when the standard of care has become, what we will be talking about in the open surgery, this mesh hernioplasty or Liechtenstein repair, then of course all these things have become very secondary, and everything that you would be doing would come from your operative assessment. Yes, one point which is where this becomes important is when you're comparing the results. So if at the time of surgery you make all these assessments and write it down and then compare your results and look at the recurrences and things like that, then it may become useful from the point of view of doing some studies, research studies, and comparison of the data, because you can then compare the apple to the apple, and that's about it. Chalo.
The second classification for the inguinal hernia is EHS classification, where the P stand for primary and R stand for recurrent. 0, 1, 2, 3 are they according to the size, where 0 is less than 1. Actually, no hernia detected. 1 is less than 1.5, and 2 is less than 3. 3 is more than 3 centimeter, where more than 2 fingers can be inserted in the inguinal hernia defect.
Mm-hmm.
X is not investigated. L is lateral or indirect hernia. M is medial or direct hernia. F is femoral hernia.
So
This is
this is
another.
a classification based upon physical examination, ultrasound,
Yes,
or
sir.
CT? Huh?
This is mainly clinical examination based on the
Clinical
clinical examination.
examination. I'm not aware of if there is any investigation involved. By and large, we have been doing hernia surgery with clinical assessment alone, and it's only
So,
when the patient has hernia-like symptoms, but hernia is not visible or not detectable, that we move on to doing something like some
yes, sir.
investigations. Okay. But
Yes,
other than that, I think these classifications, as I mentioned, have only utility when you are comparing the results of surgeries in two different set of procedures. And when you compare, you have to have the groups which are similar.
sir. Now we'll be discussing evolution of inguinal herniorrhaphy. Uh, more
And
than seven.
okay,
There,
ठीक है, quickly now you move quickly. We have set the tone. Now you can move quickly.
there are more than 70 different types of named tissue repair of inguinal hernia. Most commonly used one is Soldy's, Besney's, and McVeigh. Besney was first, out of which Besney is the oldest one, which was performed in 1887 and became a standard of care for inguinal hernia repair. But it causes tension in the posterior wall, where its more focus is on reinforcement of the posterior inguinal canal using transversalis pasa, transverse abdominis, and internal oblique muscle, and suturing them all together. However, this causes increased recurrence rate in the hands of less experienced surgeons, and which followed for Soldy's repair, which gained in prominence in early 1950s in Canada. The concept of tension-free repair was first developed in 1980, uh, after which Lichtenstein women's mesh hernioplasty was recommended, where the mesh is placed in between the layers of external oblique and internal oblique, becoming well incorporated in the lower abdominal wall. The use of technique also reduce the recurrence rate in the patients.
So when you can, yeah, I think get to the next. Yeah, yeah, sure. Hmm.
Uh, Now we'll be discussing the type of inguinal hernia surgeries. First, broadly, we divide the surgery into herniorrhaphy and hernioplasty.
So I
In
think you just move on to say that there's a tissue-based repair, and
Yes,
there
sir.
are all
Hernioplasty.
repairs under tension and tension-free repair, which is done with the help of some kind of a prosthesis.
Yes,
Right. So
yes,
herniorrhaphy
hernia.
would mean that you are strengthening the posterior wall by
Yes,
using patient's own tissues.
yes, sir. Yes, sir.
And one
We
thing that you have not mentioned here is one of the things which is becoming very popular these days, coming from an Indian surgeon, Desarda's repair.
Yes, sir. This Sada repair must be in
So I think this
herniorrhaphy.
is, uh, I
Yes, sir.
think
Hernioplasty.
that is using patient's own tissue for strengthening the patient wall and getting the tissue from nearby region. Have you taken a slide for that? The Sardas repair?
No, sir. I missed that thing.
Oh, this is, I think, very important for you to understand. And I think its utility is becoming much better. We'll come to that in a while later when you move on. Chalo.
Uh, Example of herniorrhaphy repair is Bassini, Soldy's, McVeigh, and Darning herniorrhaphy. In example of hernioplasty is Reichenstein, Gilbert's, Stopa repair, and laparoscopic repair. That is all together another.
What is the name of Stopa's repair? Giant prosthetic replacement of the visceral sac.
So,
That is the full name of this. And you place a large mesh to duplicate the function of transversalis fascia. So this repair is, I think, the basis of our laparoscopic repair. Particular paradigm has been adopted by the laparoscopic surgeons, and even when we are doing these repairs like repair of large these incisional hernias, retromuscular and reef stopper repair, become a major technique of doing these things. So you have to understand what is Stoppa's repair and how it has been adopted for the laparoscopic hernia repair or endoscopic hernia repair.
now we will be discussing
So tension under repair. Herniorrhaphies would generally result in some kind of a tension in the
yes.
region because you are just attaching the structures which are not, by nature designed to move together. They are diverging from each other. So now if you are bringing the two structures together, like you are bringing the conjoint tendon with the inguinal ligament, so you are creating something which is not designed by the anatomy. So this repair will always be because the root of the conjoint tendon is away from the inguinal ligament. You are bringing it together, so there will be some amount of tension there. And whenever there is a tension, the quality of tissue that you get is a poor quality tissue.
Yes, sir.
And the collagen that you get is type 1, not type 3 collagen.
The most matches.
Chalo, bolo.
The first one is Bassini repair,
Hmm.
uh, where we start with the transversalis fascia from the internal link to the pubic tubercle, exposing the preperitoneal fat, and we stitch the first stitch over the triple layer and the pubic tubercle and the rectus sheath. This is the strengthening of the posterior wall. The repair is carried out laterally with the triple layer sutured to the selving edge of the inguinal ligament in an interrupted fashion until the internal ring is closed medial. So this is the
What? There are many ways of doing Bassini's repair, and I don't know from which book you have picked up this, but there are many ways of doing Bassini's repair. The classical way is that you pick up the tendinous fibers of the transversalis fascia. If you look at the conjoint tendon, there will be part of that fascia posteriorly or part of that muscular, contribution of the transversalis fascia, which will be tendinous in nature. So your aim is to oppose this to the inguinal ligament, right? So you're taking one stitch to the tendinous portion of the conjoint tendon, which is a contribution of the transversalis fascia, and then attaching it with the downturn inguinal ligament. In the process, you are taking some kind of a, plicating suture to the transversalis fascia, where you take all these sutures, start tying from above or downwards, above and sequentially one above, one down, so that when you come in the center, there is less tension and you can oppose it. Aim is apposition. Aim is to bring them together without tension, right? If you tight them together, then it is like stitching them together. It's not. It is opposing them together, bringing them together with the least resistance. So that's the whole purpose. Taking a stitch to the tendinous portion of the transversalis muscle, which is a little deeper layer of the conjoint tendon, and then taking a plicating suture through the transversalis fascia, and then taking a bite through the inguinal ligament. Right. So this way you will take 5 to 7 sutures depending upon patient's anatomy. Start tying from both above and below so that when you come in the center, there is minimal tension. Right. So this is one standard way that I have been doing this repair, but there are many ways of doing it. So I think there is a modified Bassini's and there is an original Bassini's, but most of the people would be doing like what I've told you. Right.
yes, sir.
So this repair will be under some degree of tension. Never make a slide like you have made. It is too busy a slide. One can't read anything. So if you want to have something useful on your slide, make 2 or 3 slides, but everything should be very crystal clear what you are wanting to tell. Okay, tell us about the shoulder repair.
This is the advancement of the best knees repair, sir.
Hmm.
Uh, where we stepwise incise the layers of the inguinal canal. First one is starting with the application of the local anesthesia along the inguinal ligament, starting from ASIS to the pubic tubercle, uh, along the inguinal ligament above 2 centimeter midpoint. We take an incision.
I'll tell you, the
Cut
Shoulders Hospital is a specialized hospital in Toronto, Canada
your-
for hernia repair. Mostly, I think, inguinal hernia repair. And, they have the largest series, and that they do all their work with the local anesthesia, under local anesthesia. And most of the people working there are not even, full blown surgeon. Some of them may be just medical officers who have been trained to be doing this repair day in and day out. And the kind of results that they have given on this repair has not been reproduced by other centers, because people don't have that kind of localized focused training in shoulder repair. So what does shoulder repair kya hoti hai? What is shoulder repair? What is the how is it different from Bassinis repair?
This is stepwise suturing in layers. We do a triple layer suturing.
ट्रिपल लेयर किस
Uh,
किस के बीच में करेंगे?
Posterior wall to this one is the
देखो,
first line of suture which
सबसे पीछे ट्रांसवर्सैलिस फेशिया पड़ा, राइट?
uh,
सो you will remove the transversalis fascia which is attenuated. जो part weak हो गया है, you will remove that, and then you double breast it, right? So
yes sir.
you do double breasting with some non-absorbable suture. Okay, so
Mhm.
that is equivalent to two layers of
Yes.
repair. If you do a double breasting, it becomes that one layer you have done it in two different levels. Then you would do the this tendinous portion with the iliopubic tract, and then you will do the internal oblique portion of the this conjoint tendon with the inguinal ligament, right? So here you are doing repair at three different levels in the and transversalis fascia. You have excised that portion which has become attenuated. Then you do a double breasting if it's possible to double breasting. Otherwise, you do a closure with the regular suturing. And then, of course, tendinous portion will be attached with the iliopubic tract, which is a little deeper to the inguinal ligament. And then the internal oblique part of the conjoint tendon will be attached or sort of sutured with the inguinal ligament. So this becomes a four-layered closure or four-layer reinforcement of the posterior wall. Sometimes, there may not be that kind of, laxity in that region. So you may have to do what's called as relaxing incision, so that all these structures which are present medially can
Yes
be
sir.
moved little more laterally, so that you can have a good repair with least amount of tension. So remember the term relaxing incision, which may be required in this repair, right? Anything
Yes sir.
else that you have read about it?
No sir. This is the no.
Okay. So I think anybody who has a question can at the end ask me the question, and we'll try to answer you. Okay, move on.
This is another diagrammatic representation of Soldy's repair, sir.
Yes.
Will where we step wise, and here we also see relaxing incision.
Mhm. So
Right.
relaxing incision on the anterior rectus sheath,
Yes.
starting from pubic tubercle and going all the way up to the lateral margin of the ligament, lateral margin of the uh, rectus muscle. So that will result in a movement of the structure laterally, so that your repair is not under tension. So you should know how to do the relaxing incision.